Thank you, everybody. I have the pleasure of introducing two incredible individuals, two individuals that are leaders in, they're wonderful clinicians, leaders in research and clinical trials, and also some of the biggest advocates in our community that support our community. And just wonderful to have them both here with us today. Dr. McAdam is one of Canada's top researchers, and she does many clinical trials here in Canada. She's a pediatrician, and she leads a large multidisciplinary neuromuscular clinic at Holland Bloorview Kids Rehab Hospital in Toronto, Canada's largest children's pediatric rehab hospital. She has completed the Global Clinical Scholars Research Training Program at Harvard University. Her research is focused on enhancing care of patients with neuromuscular diseases, primarily Duchenne muscular dystrophy. And then we also have Dr. Leanne Ward, is our world leader in bone health research. She's been a champion in skeletal health field with her research and advocacy in the areas of osteoporosis and pediatrics. She's the founder and chair of the Canadian Pediatric Bone Health Working Group. And during this time, her research and clinical care have been focused on children with bone morbidities due to serious illnesses such as Duchenne. She is a lecturer and is in very high demand internationally, so we're very, very happy to have her with us this weekend. Her research program is dedicated to the study of bone development and the diagnosis and treatment of bone disorders in children. Dr. Ward has served as the medical director at the CHEO, which is the Children's Hospital of Eastern Ontario Pediatric Bone Health Clinic, and the scientific director of the Ottawa Pediatric Bone Health Research Group. And so the topic of today is adrenal insufficiency, adrenal crisis, and dealing with emergency situations. And I just want to say the information that these two incredible individuals are going to be sharing with you today is so, so important. It could save lives. And I really hope that none of us end up in an emergency situation, but should we end up in that situation, the information you're going to learn during this session is going to be critical for everybody. So thank you so much, Dr. Ward and Dr. McAdam.
Great. Well, thank you so much for that kind introduction, Nicola. And I must say it's just an absolute pleasure to be here working with this forward-moving Defeat Duchenne Canada and to meet all of you. And I'm just really honored to be part of the narrative that's going on in this room and also nationally. I just want to also share with you that I am from Tempsford, just a little town outside of London, and it's always a pleasure to come to London and to work with Dr. Campbell and others who are doing just really great work in the area. In the late 90s, I was aware of John Davidson's and Jesse's story as it was evolving growing up here, and so I feel like sort of a coming full circle working with Defeat Duchenne Canada in contemporary times. So thank you again. So I'm going to be talking about adrenal suppression management, and you're probably saying, well, why is she talking about that? She's a bone disease physician, but in fact, I'm an endocrinologist as well. So we certainly take care of, as endocrinologists, with adrenal suppression management, as well as other endocrinopathies that are related to steroid treatment. So Dr. McAdam and I have a little cart and pony show here that we've put together for you to walk you through this really important topic. Before I start, I should just say my disclosures. So I have been a consultant to and participated in clinical trials with a number of partners who are bringing novel muscle and bone therapies to children, including Amgen, Reveragen, PTC, Santhera, and Edgewise, with funds to my institution. So what is adrenal insufficiency, also known as steroid suppression or steroid dependence? So you may hear these terms used interchangeably. It starts with the adrenal gland. The adrenal gland is this cute little gland that on the left sits on top of the kidney adrenal, and it produces a life-sustaining hormone called cortisol. When an individual is on steroid therapy, and it could be in any disease context, not just in the Duchenne context, and that adrenal gland goes to sleep and it says, I don't need to produce cortisol any longer because I'm getting steroid through other means. So the adrenal gland is there when there is adrenal insufficiency or adrenal suppression. It's just gone to sleep and is not working optimally. The adrenal gland is like a factory. There's a number of different steps that go on in order to create cortisol, this critical, natural, life-sustaining hormone, and the role of cortisol in our body is really like gas in your tank. We need cortisol to live. So we're talking today about a really important aspect of steroid treatment. We need cortisol to live. It gives us our energy, our stamina, our endurance. It helps us maintain blood pressure in the face of serious illnesses like febrile illnesses or car accidents, and we simply can't live without it. So this is about as medical as I'm going to get with this slide, but here's what happens to make cortisol, and then in another slide I'm going to show you what happens when an individual is on steroids and why cortisol production goes down. So under typical circumstances, the brain, an area of the brain called the hypothalamus, produces a hormone called CRF, which tells the pituitary in the brain to make a hormone called ACTH, and then the ACTH sends a signal to the adrenal gland to make cortisol. And the moment someone is on steroids, also known as glucocorticoids, for long enough at high enough doses, and Duchenne would be one of those scenarios, then the signals get turned off at the level of the brain, and the CRF and the ACTH no longer tell the adrenal gland to produce cortisol. And that's why I say that the adrenal gland is fundamentally okay, it's just not being stimulated. It's not waking up in order to produce cortisol. So cortisol is important for the body's ability to handle medical stress. Under typical circumstances, if any of us in this room were to be in a car accident or have a major fracture or to have a febrile illness or to have a vomiting illness, our natural cortisol in the body that we're producing would go up to help us fight that situation. On steroids, that's blunted. So the kinds of situations that we consider important in this context include fever, vomiting illness, accidents, and also surgery. And that's a really important concept as well that I'll come back to in a minute. So when a patient is on steroids and has a medical stress, we have to give them extra steroid to mimic the body's own natural response, which it normally would undertake to deal with the situation. And we do that either through oral steroid, hydrocortisone, or getting extra deflazacort or extra prednisone, or we do it via intramuscular hydrocortisone, which is a naturally occurring sort of mimic of cortisol. Without steroid stress dosing, then patients can have the following symptoms, and this is really what we want you to understand when you walk away from this talk today. We can be fatigued, very nonspecific, but if you lack cortisol because the adrenals have been turned off, you'll be more tired than usual. Nausea and vomiting, headache, body aches and pains, and low blood pressure. Now, the issue with these signs of adrenal insufficiency or adrenal suppression is that they're very nonspecific, and they're often attributed to other aspects of a child's condition, like they just had a busy day at school and that's why they're tired, or they have a gastro and that's why they're vomiting. But anytime we see any of these symptoms in our patients who are on steroids, we have to be thinking that the problem could not necessarily just be illness, but could just be that they're lacking steroids and need stress dosing. Now here's the long list of signs and symptoms of adrenal suppression or adrenal insufficiency, and I'm not going to go through all of them again to make the point that many of them are non-specific, but abdominal pain, confusion, dehydration, headache, loss of appetite, nausea, as we said earlier, rapid heart rate, et cetera, et cetera. And as physicians, we're trained to identify the signs of adrenal suppression and adrenal insufficiency in the emergency room, for example, if we think of it in the first place. And that's what we want to do today, is we want to empower all of you to have adrenal insufficiency on your mind, so that if you have a loved one with Duchenne and you're taking them to the emergency room because they're unwell, you can say to the care provider, my child is on steroids and we need to do stress dosing. And the moment you say that, an emergency room physician is going to know exactly what you're talking about. But in the course of a very busy ER shift, they might not think about it unless they're triggered. So we're empowering you today so that you can be part of that advocacy. So how do we give steroid stress dosing? So we want to partner with you so that you have a mechanism for getting things going at home. And in fact, we can even keep you away from the hospital. if you have adrenal insufficiency by following some of these simple guidelines. So first of all, your loved one with Duchenne or you needs extra steroids in the following context. If there's fever, and we define fever as greater than or equal to 38, there's different degrees Celsius, there's different definitions that are out there, but this one is simple, 38 degrees or more. That defines a fever that's sufficient enough to warrant extra steroid stress dosing. A cold with flu-like symptoms that are bad enough to stay home from school, so not the kind of cold where you just have a bit of a sniffle, but you otherwise feel well, where you're really just unwell and staying home from school. Surgery, whether it's dental surgery or surgery for a femur fracture or for any other reason, appendicitis, or an arm or a leg fracture. These are the situations in which the individual on steroids would need extra steroid. There's a few ways to do steroid stress dosing. So I'm going to map those out for you, and they're both fine, they're both correct, and there's quite a bit of practice variation across the country. So if you're talking to each other and your physicians are recommending different approaches, that's okay. There are different approaches to do this. One way to do steroid stress dosing orally is to take the usual prednisone or deflazacort in the morning for the treatment of the underlying condition, whatever that is, and then to take 50% of that dose in the evening. So that's giving a little top up to help ride out this illness. So for example, if you're on 24 milligrams of deflazacort daily, then your top up in the face of illness would be an extra 12 milligrams at the end of the day. Some clinics like to use hydrocortisone, which is a very natural, like oral steroid, put together as a medication, because it's shorter acting and it better mimics what the body would normally do. So many of us prefer hydrocortisone, but deflazacort or prednisone given at that 50% dose is also fine. In the case of hydrocortisone, if you needed extra steroid stress dosing at home orally, you would take your usual prednisone or deflazacort in the morning, and then in the face of these triggers for steroid dosing, you would take extra doses of oral hydrocortisone 8 hours later and then 8 hours after that. So you'd have 3 doses in the course of a 24-hour period. So different ways to do it, and they're all acceptable. And the most important thing is just to know to do it and to have a plan. Now, what about vomiting illness? The problem there is that if you're vomiting, you can't keep down oral steroid, right? So for the stress dosing, that then becomes a challenge. So then we give intramuscular hydrocortisone, and we teach the families how to do this. And the families are very capable of learning how to do this. We've developed a video out of CHEO that we can share with you, and we should put it on the Defeat Duchenne Canada website. And because, it's the kind of thing where you should go back every 6 months or so and just remember how to do this injection in the muscle. So vomiting illness, you're at home, your child or you're on steroids, what do you do? If you're unable to keep your daily prednisone, daily deflazacort, or daily vamorolone down for at least 45 minutes, you need intramuscular hydrocortisone. If you have more than one episode of vomiting in a 24-hour period, then we would recommend intramuscular hydrocortisone, even if you kept your regular steroid down earlier in the day. Now, there's a little gray zone for that comment I just made, referring to what is written there on the right. If you vomit a couple of times, but your child is otherwise really well and engaged and alert, you don't necessarily need to go right away to intramuscular hydrocortisone. You could try the oral and see if they keep it down. But the bottom line is, if the child is unwell, or if you're not sure what to do and what's best, it's always best just to do the intramuscular hydrocortisone and then seek guidance on what to do after that. So we have a low threshold for optimizing the steroid stress dosing paradigm. Did I go the right way here? Sorry, yeah. Go back. Right, so again, these are the situations where you would need to think about oral or intramuscular hydrocortisone. In the setting of an accident, this is a situation where we want you to have a medical alert bracelet so that if there's an accident, somebody was there to assist on the paramedic side, they would see the medical alert bracelet and know immediately that this is a situation where steroid stress dosing is needed. And then before surgeries, important to have an extra dose of steroid intravenously as the child is going off to sleep for the surgery. So this is something you need to talk to with the surgical team about. Now, another really important concept is something called fat embolism syndrome. How many of you have heard of fat embolism syndrome? Okay, good. We're starting to see that hands are going up in the room, so that's good. We're getting this message out. Now, you can see that I've referenced Dr. McAdam down at the bottom. She has published on this phenomenon. So this is something that has occurred in Canada, and we hear about it periodically in the Duchenne community around the world. This is a very serious consequence of a bone fracture or even just a bone bruise. You do not have to have a broken bone for this to happen. And I want to tell you about this because A, it's an emergency, and B, you need stress dosing to protect the adrenal situation. So here's the thing. For anyone on steroids in any context, particularly though if they are not walking normally, there's an accumulation of fat cells in the bone marrow called adipocytes. At the time of a bone fracture or even just a bone bruise, I've seen fat embolism syndrome when a child has just bumped their arm on the wall as they're sort of wheeling by. Anytime there's a fracture or a bone bruise, these fat cells get dislodged and they go into the bloodstream. They form fat globules and they shower the lungs and shower the brain and can cause respiratory distress and cognitive deterioration. So this is a medical emergency, and there have been, unfortunately, cases of individuals with Duchenne on steroids passing away from fat embolism syndrome that has gone undetected. And this is a situation that requires stress steroid coverage, and it also requires an intensive care admission. You can often see the little fat globules at the backs of the eyes, so that can be a quick test to look to see if this fat embolism syndrome is going on. So anytime you have an individual on steroids and they have neurological deterioration or respiratory distress, in the hours following the event, you need to be thinking about fat embolism syndrome. And this is rare, so the emergency departments might not be thinking of this top line. They might think, well, this just looks like pneumonia. And so you have to tell them, well, it could be pneumonia, but it also could be fat embolism syndrome, and I want you to look at the backs of the eyes of my loved one, and I want you to think about this and put in place the necessary treatment. So all patients with Duchenne muscular dystrophy on steroids need to be educated on the signs and the symptoms and the at-home management of adrenal insufficiency, and also this dialogue that you need to bring to the emergency room if your child or your loved one is very unwell. Also important just to have someone to call when you're trying to manage this at home. So we really encourage you to discuss with your care providers who you should call if there's illness at home and you're trying to manage this with oral steroids, or you've given intramuscular hydrocortisone and you're looking for guidance as to next steps. So what are the next steps if you're giving steroid stress dosing in the home, depending on what you had to do? If you gave intramuscular hydrocortisone, then you should contact your pre-arranged healthcare provider for next steps. If you can't reach anybody, you go to the emergency room. If you gave oral hydrocortisone, then you continue the stress dosing for as long as the child or loved one is unwell. And if it goes on more than 2 or 3 or 4 days, then you should be calling your healthcare provider for more guidance. And there's a little bit of a judgment call there. If you're doing stress dosing and your loved one is well, then you can just manage that at home. But if you're not sure or the individual is not getting better at home, then you really need to reach out to your care provider for next steps. Now, you need to carry around a little wallet card, and Defeat Duchenne Canada has done just this beautiful example here that's in your bags. And so these are just great. Kudos to Defeat Duchenne Canada for putting that together. And it talks about adrenal suppression management, and it also has other guidance for what to do if you need to go to the emergency room. So the way I think of intramuscular hydrocortisone, because you may be sitting there thinking, oh man, that sounds like a lot to have to do at home to give an intramuscular injection. Is anybody feeling a little overwhelmed by the fact that I've mentioned this? Or are you all feeling like, no, we got this? Yeah, right? So I expected you to feel that way, and we understand that. And so for this reason, we've created a video to remind people how to do it. Your care provider team will teach you how to do it and support you so that you're comfortable. And the way that I think of intramuscular hydrocortisone is that it's like an insurance policy. Most of us don't have to cash in on our insurance policies, but if you do, then you're glad that you have it. And that's very much how I think of the IM hydrocortisone approach. Probably will never need it, but if you do, you'll be glad that you had it. Now, Dr. Campbell mentioned earlier that you do not stop steroids abruptly, right? So I just want to pause on that for a minute. So remember I told you that the adrenal glands have gone to sleep. They're there and they can wake up again, but they take time to wake up again. If you stop steroids abruptly, you will cause adrenal suppression. So the way that we do it is we do a steroid wean. If you've decided with your healthcare provider that you want to come off steroids, then we develop as endocrinologists a weaning schedule that allows you to come off steroids gradually and for those adrenal glands to wake up. So as you go down on steroids, the adrenal glands wake up. Sometimes when an individual comes off their steroids, they really don't feel well, in which case you go back to the dose at which they felt well, you stay on that dose for another week or two, and then you try to wean again. So this is something you would very much do in collaboration with your endocrinologist, possibly your neurologist, depending on how engaged they are in that particular aspect. And then once the steroid wean has reached a physiological dose of steroid, meaning the kind of dose that would mimic the naturally occurring steroid that we make, there's additional testing that has to be done. And I'm not going to go into too much detail in the interest of time, but we look at morning cortisol levels, and then we decide if the patient can stop the daily hydrocortisone and only needs the stress dosing. And then we do something called an ACTH stim test to see if the adrenals have completely woken up and can handle surgery and vomiting illnesses and accidents and that sort of thing. So this is all done usually in collaboration with an endocrinologist. The main message I'd like to leave you with today is that if you're stress dosing or you're thinking about it, but you're not really sure, it's always best to stress dose as opposed to not. You cannot cause any harm by doing short-term stress dosing. So we always err on the side of caution and do it, as opposed to saying, oh, I don't think we need to do it here. It's always a conservative decision. On the other hand, not doing stress steroid dosing can have serious consequences. So this really does save lives, and that's what Nicola alluded to in her introduction. So we recently put out a campaign to have a little slogan to sort of communicate this, and Rachel came up with this from Ottawa, so I don't know if you're listening, Rachel, but thank you for that. And it's, don't cut it close, take an extra dose, all right? So shall we all say that? Don't cut it close, take an extra dose. All right, we have Rachel to thank for that, so thank you, Rachel. Just to finish up, I want to say that there are a number of resources for healthcare providers like myself in order to inform steroid stress dosing guidelines, and this is one such that was developed by Parent Project Muscular Dystrophy in collaboration with the PJ Nikoloff family. So we use that, and then we now have the Defeat Duchenne Canada guidelines as well that have been put together so nicely by Defeat Duchenne Canada, and we're really grateful for that collaboration. And just like Dr. Campbell said, I would like to just reiterate that we do not want you to struggle. We don't want you to have questions and not be sure who to turn to. If I can help you in any way as you navigate this aspect of your condition, you're welcome to reach out to me or reach out to Defeat Duchenne Canada, who will in turn be in touch with me, and happy to talk to you today as well in person at this wonderful family forum. So thank you very much for your attention, and I'll turn it over to Dr. McAdam. And then I think we have questions after, or
Yes,
do we have?
Yep. Dr. Ward, just before we do that, I just want to remind everybody that the video that was referenced by Dr. Ward will be made available to everybody, and it will be on our website. So we will be sending that video along. Sorry.
Yeah, that's great. Thanks. Thanks, Rick.
Okay, so now we have learned a lot about stress dosing of steroids, and this is going to hopefully be the fun interactive component. And so I've already been introduced. I'm Dr. Laura McAdam, and I'm at Holland Bloorview, and my disclosure is that I am a principal site investigator for the Givinostat study. I'm going to go through a couple of cases, and we'll need audience participation for this. I know the people online, they will be able to do a poll through Zoom because that's the platform we're using for the people online. And here I'll be getting people to raise their hands when we're asking questions. So case 1 is about Samir. He is an 8-year-old male with DMD. He's treated with deflazacort, and he's on 27 milligrams daily. This morning, he woke up with a temperature of 38 degrees, and he also has body aches. So the question for all of you is, what body temperature is considered a fever? Well, apparently they all say A's, but I'll tell you A, B, and C. And then we will get people to raise their hands. So you're not going to go wrong if you say A. But so A, 36 degrees, B, 37.5, or C, 38 degrees. So now that I've said it, we'll go through and we'll get people to lift their hands. So is it A, 36 degrees? So we have one hand raised here. Okay, is it B, 37.5 degrees Celsius? Or is it C, 38 degrees Celsius? Woo, we have a sea of hands raising for 38 degrees Celsius. And I don't know if we're able to see it online. Generally people are saying 38 degrees? Oh, it's disappeared. Okay, so in general, we have good consensus. Excellent. So 38 degrees, and I think that's just really driving home. You will see many different temperatures that are defined as if having a fever, but here we're going to be using 38 degrees or 100.4, depending if you prefer to think in Fahrenheit. I'm trying to advance the slides to the next slide. Okay, perfect. So what should you do with his steroid medication? Once again, we're all A's, but I will tell you A, B, and C. So A, do not give his morning dose of deflazacort. B, give his morning dose of deflazacort. Or C, give an intramuscular dose of deflazacort or hydrocortisone. Okay, so we'll go through again an audience participation. So A, do not give his morning dose. Okay, no hands being raised here. B, give his morning dose of steroid medication. All right, so almost everyone has their hands up. Or C, give an intramuscular dose. So everyone here was right, and I can't see the online poll, so I'm just looking over to the right here. And so it really is to give his morning dose of corticosteroids. So it could be deflazacort or prednisone or vamorolone. But the key thing is, if you're feeling unwell, give your regular dose. Oh, I'm just seeing, it looks like pretty much everyone had the same answer online. So then the next question is, would you give another dose of a steroid medication later that day? So this time we only have two choices. So is it A, yes, I would give another dose, or is it B, I wouldn't give another dose? All right, so is it A? So I have a B, so I have a few people, so A, I would give another dose if someone's unwell with a fever. Okay, I'm seeing quite a few hands. Or B, I wouldn't give another dose. Okay, so we have some questioning here, and it looks like online, sorry, over on this side, which is why I keep on looking over there, I can see some results. So it looks like the majority of people are saying, yes, I give another dose, and some people are still a little unsure. So for Samir, so he has a fever of 38 degrees and he's feeling a little unwell. So in this situation, we would follow the non-vomiting illness and we would give another dose. So that's where you would either give a half dose of deflazacort or prednisone, or you'd give hydrocortisone, depending on what your clinic is prescribing for stress dosing. Okay, so this is just using one of Dr. Ward's slides, so a non-vomiting illness. And so for Samir, it was the fever, as well as feeling a little unwell, but it could also be flu-like symptoms without a fever, or having surgery, or having an arm or leg fracture. That's when we would give that extra half dose. Now, this is just a general medicine question, is can you give another medication to help with fever in addition to the corticosteroid? So would you give acetaminophen or ibuprofen, so that's Advil or Tylenol, if your child was feeling unwell? So is that A, yes, or B, no? So I'm seeing, so if we're thinking about yes, what do you think? Would you give something else if someone was feeling unwell? Yeah. Absolutely. And it looks like online, everyone 100% said yes. So you should absolutely treat the other symptoms, because at the end of the day, you want your child to feel okay. And so if they have a fever, you can give a medication to help lower the fever, or if they just really aren't feeling well, it's okay to give other medication in addition to the extra dose or extra half dose of steroids. All right, so when do you let your when do you let your doctor know that your child is unwell? Do you let them know immediately? Do you let them know if they're unwell for 2 or 3 days, or if you're concerned? Or do you let them know if they're unwell after 5 days? So we have A, immediately. Okay, so we have some people saying yes there. B, if they're unwell after 2 to 3 days, or if you're concerned. Okay, so we have a greater number of hands there. Or C, if they're unwell after 5 days. Okay, and when I'm looking online, so some people would let their doctor know immediately, but the majority would be if they're unwell after 2 to 3 days. And honestly, it comes down to judgment. As parents, if you're concerned, or if your child or youth are concerned about how they're feeling, you should absolutely reach out to your doctor. But if you're feeling you're managing at home and you're giving that extra half dose or that extra dose of hydrocortisone, after 2 or so days, you should at least reach out and speak to a physician to let them know what's going on, and they can help guide you. But if at any time you're concerned, you should always reach out. All right, so Samir, he had a fever the first day, just a little feeling unwell. You gave an extra half dose of steroids. The next day, he's still not feeling well. But this morning, 20 minutes after Samir took his regular steroid medication, he vomited. And after that, he is unable to keep anything down. So what would you do now? So we have 4 choices here. So A would be wait until tomorrow to give his regular dose of steroid medication. B, immediately repeat the dose, so give him another dose by mouth. C, give him the extra steroid dose by mouth in the afternoon, so you're not repeating the morning dose. Or D, give an intramuscular dose of hydrocortisone. Okay, so now we'll ask everyone in the audience here. So A, would you wait until the next day and then give him his regular dose of medication? So I'm not seeing any hands there. Looks like online no one has opted for that. B, immediately repeat the steroid dose. So I'm not seeing any hands. I'm seeing maybe some people online are thinking about that. C, give him an extra dose of steroid by mouth in the afternoon, so giving that half dose. Okay, so I'm seeing some people thinking about that. And then D, give an intramuscular dose of hydrocortisone. Okay, so I'm seeing a few more hands there. And that's definitely what we're seeing online as well for the online participants. So once again, this is going to come down to judgment. But if Samir cannot keep anything down, I would recommend giving that intramuscular dose of hydrocortisone, but you're also going to have to go to the emergency room because we worry about dehydration and what are you going to be doing with the next dose. But I think it's really going to come down to what you're seeing at home and how comfortable you're feeling. So with this question, I always see multiple answers, and it's really going to be based on what you're experiencing at home. But if in doubt and you're not able to keep anything down, we need to think about those snoozing adrenals. Your body or his body isn't going to be able to make that cortisol that it really needs. So that means we have to be supplementing and giving him more. All right, so after you give that intramuscular dose of hydrocortisone, what do you do next? Just watch him at home, see how things are going, so that's A. Is it B, do you call the endocrinologist or the neuromuscular team? Is it C, go to the nearest emergency room? Or is it a combination of B and C? So calling someone and going to the emergency room. So we'll go through for the group here. So A, would you just monitor him at home? Okay. Is it B, would you call the endocrinologist or call the neuromuscular team? Okay, so I'm seeing some hands. Is it C, go to the nearest local emergency room? Some hands. And then, or is it D, where you do both, call someone on your team and go to the emergency room? Yeah, and so I'm seeing some hands there as well. So online, what we're seeing is some would monitor at home, a few more would call, a few would go to the emergency room, and the majority would kind of do both, B and C. And so I think, once again, it's going to come down to your clinical judgment, but if you're having to give that intramuscular dose of hydrocortisone, you need to talk to someone, and if you can't get in touch with someone, you have to go to the emergency room, because that intramuscular dose is really going to tide you over for about 6 hours time. And so we want to make sure that you have a good plan next as to what you would be doing. Okay, we're switching gears a little bit. This is case 2. So John is a 15-year-old with Duchenne. He uses a wheelchair for mobility. During a transfer, he had a fall to the ground. He immediately experienced some leg pain. His parent was able to transfer him onto the couch and was comforting him, and he developed a headache about 15 minutes later and had some difficulties breathing. So what would you do next? This one, we have lots, and look, all my letters did work this time. All right, so we're going to either A, wait and see if things get better, B, call 911 or an ambulance, C, give an intramuscular dose of hydrocortisone, D, give oral steroid stress dosing, or would we do some combination of things? So call an ambulance and give intramuscular hydrocortisone, or call an ambulance and give some more steroids by mouth. Okay, so for the room, would you just wait and see if the symptoms get better? So it looks like everyone's saying no, they aren't doing that. And online, they're saying the same thing. Would you call an ambulance, call 911? So I'm seeing some head nodding here. C, would you give an intramuscular hydrocortisone dose? So I'm seeing some hands and some head nodding. Or would you do a combo, call 911 and give hydrocortisone? So I'm seeing a few hands. Oh, I'm seeing 2 hands by one person, so enthusiastic about that answer. And, or would you call 911 and give an extra dose by mouth? So I'm seeing a hand raise and a hand raise. Okay, so online, the majority of people said F. So, and I think the key thing is calling 911. So we already have some leg pain. There's probably a fracture going on at this point if it was significant. And we're also acknowledging that we're going to need extra steroids because there's something major that's happened. Now, I just wanted to bring you back to what Dr. Ward talked about was fat embolism syndrome. So she talked about how there's some fat or adipocytes that are in your bone marrow, and when there's either a bone bruise or a bone fracture, this fat travels through the body, so through the blood circulation can go to the lungs, because John, in this case, he had some breathing issues. So that's giving us a hint that something's going on in the lungs because of the fall. It also can cause some neurologic symptoms. And so John, in this case, had developed a headache. And so this is telling us that the fat has definitely traveled to other places in the body, and this is a medical emergency. And so in this case, it would be really important to call 911. And the caveat for this with fat embolism syndrome is sometimes we can see it immediately, but sometimes it can take up to 72 hours. So some people would have already taken their child to the emergency room, they've either put a cast on or they've fixed that fracture, and they could be back home. And so it's one of those things, you may see it immediately, or it may take some time to evolve. So if it's evolving and you're back home, or you're in hospital and you're saying, whoa, something has changed, you need to tell them about fat embolism syndrome. It's really about you advocating for your child in that situation. Because I agree with Dr. Ward, many people won't think about this. This is something we do not see commonly in pediatrics, and we also know how busy the healthcare system is right now, so it's going to be about advocating for your child, saying we need to think about this. And I really like Dr. Ward's picture. If you have a fall, you have some either breathing issues or neurologic issues, if this is a medical emergency and you need to call 911. And if you're on steroids, you need that extra stress dosing of steroids. This can also happen if you're not on steroids. So you need to be aware of fat embolism syndrome. So I just want to finish by thanking the entire audience here, both in person and online. And I'd like to thank Defeat Duchenne for having this conference and helping spread this information, as well as thanking Dr. Ward for all of her leadership in both bone health, as well as bringing awareness to adrenal insufficiency. And I just want to echo, these cards are amazing. At the end of the day, don't cut it close, take an extra dose. And that really should be the mantra for all of us in this room. Thank you.
Thank you, Dr. McAdam, and thank you, Dr. Ward. And just to remind everybody, the resources that we're speaking about, they are available on our website. I'm hoping everyone did get some of these delivered to their homes already. So if you're connected to Defeat Duchenne, you would have gotten a package in the mail where you did get an emergency card, as well as the wallet, the other card that you can attach to a bag or a wheelchair. And there's more information on the website that you can access as well. And as Rick mentioned, the video on how to administer hydrocortisone is also on the website, and we will be sending it out so that everyone will have access to all that information. We'll open it up for questions. I think it'd be great to take some questions. Any in the audience? Rick, did you? I can.
So we're just going to take a, I have a quick question online. How do we get in the intramuscular hydrocortisone dose? How do they get that?
So depending on how your center is set up, you would get a prescription from either your neuromuscular team or the endocrinologist that's following you. And someone on those teams teaches you how to give the injection. And then you would go to a pharmacy to be able to fill that prescription. So it's really working with your local team to and asking them, and they'll have a strategy in place.
Yeah, and I'll just add that the intramuscular hydrocortisone dosing, as well as the oral, is body size dependent. So every visit or every couple of visits, the endocrinologist or the neuromuscular physician who's ever prescribing has to look to see if the dose is current or whether it needs to be adjusted upward as the individual grows.
If I can add one thing to that as well, on the actual cards, there is a section where you can put in your prescribed dose. And you may need to update that as well as time goes on, but the card is meant as a resource for you, because in an emergency situation, sometimes we're just not in a place to be able to communicate all this information. And so we're hopeful that these cards are something you can literally hand it to someone in the ER department. It has all the information there that they need to know to help your child or yourself.
And may I just add one other little comment is, so emergency room physicians will know the steroid stress emergency dose. Like that's just a common knowledge. The key is for them to think about it in the first place. And that's where you come in. You're just going to mention it, and then they will know what to do from there. But also good to have it on the card.
It's important to, because deflazacort is not, we brought into this, deflazacort is not always known to emerge docs, and they can overlook that it's a steroid. So prednisone, no problem, but emerge docs, you really have to tell them deflazacort's a steroid.
Yeah, and for the people online, just in case you didn't hear that, we were just saying that deflazacort is really only used in Duchenne muscular dystrophy in Canada. So emergency doctors will not know, or will likely not know that this is a steroid medication. So that's where it's so important to say, my child is taking deflazacort, it is a steroid medication. So then it can trigger the next thought processes around stress dosing.
And did you want to say anything too about vamorolone? So I know there are some families in Canada as well that are in the trials that are accessing vamorolone, which is also a steroid. Did you want to make a comment on that too?
Yeah, so vamorolone is a dissociative steroid, so it is under trials at the moment, and we're just really learning about vamorolone. But one of the things we do know is that if you're on vamorolone, you do also need to do steroid stress dosing. So we treat vamorolone the same as deflazacort and prednisone. They all cause potentially adrenal suppression.
And just one, sorry, one last thing is, if you are in the clinical trial, you should receive a card or something that gives instruction on what to do in that type of situation. So, and if you don't have that card, make sure that you do have that with you along with all your other information. Sorry.
First of all, to thanks Dr. Gord and Dr. McAdam for the presentation. Is very, very useful, I think, for everybody. I have some questions. First of all, the bones density test study. Which is the purpose for this study, for this test?
So I'm going to be talking about that this afternoon. So I'd be happy to go that in detail for you with some pictures. Would it be okay if we talk about that in the presentation this afternoon?
Perfect, perfect. Other question. We miss you, Dr. McAdam, a lot. After the time that we divorced, we are like in a limbo. We have no real support, and Diego is always asking for you, because some of the questions that you ask us today is to whom we have to go in the case that we have debts, or in the case that we have problems. And the answer is in the team. We have to support in the team. But after you, we have no team. We have no support team. We have only a doctor that following up him every year, but no support. Why I tell you this? Because we never know anything about the intramuscular hydrocortisone. And we never know that the SSD is the one of the good things to know when we have to visit the emergency room. As the doctor also say, this is not true that the emergency rooms knows that, because we visit several times the emergency rooms and they have no clue about this. And we have to insist them about the medication, the medication that the deflazacort, and after that, they act accordingly. But I don't know if it's a question or not, but what we can do in the case that Diego needs some support, because we don't know, to be honest, we don't know what we can do.
No, so thank you. You bring up so many really important points. You are absolutely right. Across Canada, we don't have, or in many areas across Canada, we don't have the same type of clinic support from an adult standpoint. And every city is coming up with different transition plans to different adult doctors based on what's available. And you're right, in Toronto, we don't have the same counterpart of having someone that follows individuals with Duchenne from a steroid standpoint. We have other adult healthcare partners, but we don't have that. But I want you to know it is something we're very aware of, and we are absolutely working on trying to fill those gaps, as I know they're working in many other communities. And I think that's also where our partnership comes with Defeat Duchenne, to try and ensure that the adults with Duchenne are aware of the changes in care, because there have been so many changes in the last 5 years. And I know 5 years ago, we weren't teaching families about the intramuscular steroid injections, but now we are actively doing that at almost every clinic visit. So as the field is changing, we have to make sure we're reaching the adults with Duchenne to ensure that they're getting that information. And that's where I'm hoping the partnerships are going to be very helpful in getting that message out. But we also have to figure out how we can best reach the adults with Duchenne, because there are so many, and it's continuing to grow, the adult population.
Yeah. And again, this speaks to, regardless of where you are in your journey, right, the self-advocacy. So when the minute, we are diagnosed with Duchenne, it becomes, we become self-advocates, and we're constantly advocating for our children. And you are the expert. You know your child better than anyone else, right? You know when your child's unwell, or your young adult, or you yourself, if you're an individual living with Duchenne, you know your body best. And you just need to be able to communicate that. And we are here as an organization to help provide you with the tools to do that, which is why we have developed, and just to Dr. Ward and Dr. McAdam were integral in helping us develop these materials, as well as Dr. Min, who's a respirologist at Toronto Sick Kids Hospital, that helped us put these materials together. But at the end of the day, if you don't have the information that you need, or you're not finding what you need, then reach out to us, because if we don't have that information, we will find it for you. We will know, we will figure out where to get that information for you too. So just know that there is support here. We might not have all the answers, but we'll certainly try our best to find those answers for you. But at the end of the day, it really is up to yourself to go in there and advocate for yourself. And if you have tools to support you, fantastic, right?
Thank you both. We just have 3 questions online, and I appreciate everyone in the room. We are running into lunch, so we're a little bit behind. But the first question, what do we do if we miss a morning dose?
Well, I recommend that my patients take it as soon as they remember. And if you've, gone beyond, the time when it makes sense to do that, like you're into your next dose, then you would double the dose to make up for what you missed the day before.
Perfect. Next question is, giving the intramuscular injection can be quite stressful for the parents to draw it up. Is there another format of this hydrocortisone, for example, an auto-injector?
Unfortunately, no. This is something that's come up periodically in the endocrine world, because we have a number of primary adrenal insufficiency conditions where the adrenal glands themselves were never made properly in the first place, or there's something that's gone wrong in the factory line to produce cortisol, and we wish we had something similar, but we simply don't. I do think that this little link to a video that we've put together out of CHEO for you will be extremely helpful, and I also know whoever's asked that question that you can do it. I know you can.
Thank you. And the last question here, is adrenal suppression something to consider once you're an adult and your conditions of weight and deflazacort are stable? Should we consider stress dose, or is 30 milligrams a stress dose already?
30 milligrams is still a stress dose, and yes, you need to consider adrenal suppression across the ages. So it's not just specific to the pediatric years. Yep.
Yeah, and I guess I just want to add, it really comes down to it. Don't cut it close, take an extra dose. So even if you're an adult and you're on 30 milligrams, still give that half dose, or if your doctor prescribes hydrocortisone, you should be using that if you're unwell.
Okay.
And just one last question. Sorry, I know I'm standing in everyone's way between lunch, but this is a critical conversation, a critical discussion. So I just want to make sure everyone's getting all the information they need. But I just have a really quick question actually for our panel here. Is you talked about extra medications when you're unwell. Is there a preference between giving acetaminophen versus ibuprofen? Because we hear this a lot in the Duchenne community, that the preference is to give acetaminophen and not ibuprofen because of the heart. Do you have a comment? Can you comment on that?
So I think it comes down to, so acetaminophen is metabolized, or your body processes it through the liver. And when you're looking at ibuprofen or Advil, it processes through the kidneys. Now, it depends on your heart function, because your heart, it depends on your heart function and if you're taking heart medications. So we had heard from Dr. Campbell earlier about starting an ACE inhibitor at 10 years of age, and that also works through the kidneys. So if you are taking an ACE inhibitor, or depending on your heart function, it's better to be using acetaminophen, which is Tylenol, because that does not interact with the kidneys. And I think if you have questions about that interaction, it's actually the cardiologist. They'll be able to help you triage of, you know what, you're completely fine, that's to take it, or you're not, and you should really be sticking to acetaminophen.
Thank you so much. So thank you, everybody, and thank you again. Can't thank you both enough for all the work that you have done around this, but also for our community. So really appreciate you guys coming all the way down here this weekend and spending the weekend with us, and thank you so much.